I am Shinhyeung Kwak from Samsung Medical Center Seoul. And today I'd like to share our experience about stenting of ductus venosus in neonate with obstructive T-PVR infracardiac type. A male neonate who was suspected as functional single ventricle from fetal evaluation was born at 39 weeks of gestation with birth weight of 2.97 kilogram by normal delivery. After birth, we did an echocardiograph. Revealed that patient had right isomerism situs ambiguous, transposition of great arteries and common atrium, functional single ventricle, combined pulmonary stenosis, small PDA, and mixed type T-PVR, which was dominantly infracardiac type. Expect part of right upper pulmonary vein was suspected to be connected to zygous vein. As you see, there is almost nearly common atrium with a single ventricle. We cannot see in this view, but there was a ruminant small ventricle is left and anterior side of the main ventricle. And the great artery portion is like this. Aorta is nearly side-by-side position rather than dimal position. And about the T-PVR, the pulmonary veins generally connected to the vertical vein to the portal vein system. And you can see here the ductus venosus is still patent, very small. It seems like to be closing. As a CT scan, there is a similar finding. The pulmonary vein connected to the vertical vein to the portal vein system. So I think the presentation PPTs are changed. I'm sorry, but okay. So we decided in 2 days after birth, signs of heart failure, including tachypnea and pulmonary congestion, and feeding intolerance gradually progressed with closing ductus venosus. So because of the progress of tachypnea with desaturation, needed oxygen support, and we decided to implant a stent in the ductus venosus at 3 days of age. There is a level finding was non-specific before the catheterization. And the chest X-ray, there are increased pulmonary vasculation and congestion. So he came to the cath lab on the age of 3 days, and the procedure was performed under general anesthesia. As we are going to do jugular approach, the patient lies as a spine position, putting his head and collar aside for more convenient procedure. And the right interjugular vein was assessed with 5 French Roches. The ductus venosus was selected with run-through extrapolophy coronary guide wire 0.1014. So we did venogram. Okay, let's start from the ductus venosus stenting. The patient came to the cath lab at the age of 3 days, and the procedure was performed under general anesthesia. And the patient lied in spine position with head to the caudal part for the convenient procedure because we decided to approach the right IJV. And the right jugular vein was assessed with the 5 French Roches. And ductus venosus was selected with run-through extrapolopy coronary guide wire guided by a 4 French gliding catheter. And we did venogram, as you can see here. According to venogram, size of the ductus venosus was measured as 1.8 millimeter as a diameter, and 28.12 millimeter long. So we chose an onyx coronary stent 5 to 30 millimeter to insert, and the catheter was exchanged to the heart rate JR 3.5 guiding catheter. The stent was successfully implanted, and we can find that the waste was completely disappeared while inflating the stent here. It's a little slowly, but finally the waste has disappeared. And then, since the follow-up angiogram confirmed that the flow through the catheter was really confluent and very adequate. The follow-up echocardiogram on the next day of the intervention shows confluent flow through the ductus venosus, and the portal vein decreased of the size, and the stent is really well located. Since then, the patient was stable. The leukemia was improved, so was feeding intolerance. And in the chest X-ray, pulmonary congestion also got better. But the story went unfortunately way. He had done well until the age of a week. In several days after the stenting, the saturation below 75% SpO2 was repeated, and basal saturation was gradually decreased. Need of oxygen chest restriction, and tachypnea progressed again. Additional to these signs of progressive pulmonary overflow, AV valve regurgitation was also worsened. Eventually, surgical treatment, including internal banding of MPA and infracardiac TPV repair and PD division, was performed at 12 days of age. After the surgery, ventricular dysfunction with metabolic acidosis and acute kidney injury was developed. Peritoneal dialysis was required for AKI, but the worsened condition was uncontrollable, and unfortunately, we lost the patient on the 5th day after the operation. And that's all I have to say today. Thank you for your sincere attention.
Kwak. Thank you, Dr. Kwak, for your presentation and patience. Any comments or the question on this presentation? Yeah, Mingtai? Unmute, please. We couldn't hear you.
Sorry. Thank you for your presentation. Did you consider send the patient go ahead direct surgery at the first presentation when the patient suffer from severe cyanosis? And I have another question. After you finish stenting, did you check the ammonia, the body ammonia level for this baby?
Okay, the first question was about the cyanosis, right?
For surgery, go ahead to direct the TAPBC rerouting and the direct repair. This is my first question.
So the rationale for the choosing stenting rather than surgery, yeah, Shinhyeung must be on the mic. That's Shinhyeung, yeah, please.
Thank you for your question. I don't know about Taiwan's result in this substrate surgical outcome, but in my experience, the surgical outcome on this kind of patient was very poor, especially after the first palliation. So in my opinion, if we could pass the first shunt or bending palliation in addition to the pump surgery. So that was our object at first.
My surgeon colleague, they recently reviewed our surgical results during the recent 20 years. Actually, for the infracardiac type TAPVR, especially in the patients with isomerism, the result is relatively not good compared with the isolated infracardiac type TAPVR. However, the results still acceptable for the isolated infracardiac type TAPVR. The percentage to hospital discharge is, I forget the exact number, but around the 70% to 80%. But for the isomerism, relatively low because they have more complication for other structures, so around 60%. But for my hospital, the rule is always direct repair.
Maybe this patient has some isomerism because I have seen that the liver is bilobated and the position of Ductus venosus was not usual.
Right, yeah.
Maybe I missed that during the presentation, but this patient must have some kind of isomerism or something. Dr. Jung Kim, you have any question?
So I have one question about you used the stent, onyx stent, right?
Yeah.
So this is drug-eluting stenting, right?
Yeah, I think so.
So this kind of immunosuppressant is kind of tacrolimus. So it is, could you rule out the sepsis because of the stent, using the stent?
Well, we used the pre-catheterization antibiotics, of course, and after the catheterization, the CRP was not elevated. So,
Yeah, because use immunosuppressant. So I
you're
think
right.
it's neonate cannot elevate the CRP using on septic conditions. But how about?
So Jung Kim, you never use such kind of drug-eluting stent?
I'm just curious because
Okay.
to neonates. So.
Okay, let's hear from the
yeah, I think it
Shinhyeung.
was, yeah.
Well, frankly speaking, I just used this stent because technician gave us that stent, not for the
It's a
reason.
practical, yeah.
Usually nowadays, every stent in pediatric neonatal cath lab, usually we use the drug-eluting stent, but I don't have experienced any adverse event.
Do
especially
we have a bare metal stent that
yes,
size?
maybe, but I didn't ask specially not drug-eluting bare metal stent. Just they gave us that.
Actually, the radiology technicians have a lot of knowledge on the stent because they always have conference on that. So that's also my practice that ask them which kind of option is there and which would be the beneficial. And I heard that recently maybe we are shortage of bare metal stent on that size.
Yeah.
I guess Dr. Tae-Wook Jeon may have something to say about the outcome of this kind of patients. Tae-Wook Jeon. Can you comment on Dr. Song's? Yeah.
I'm sorry, I have no idea, but actually the obstructive TAPVR with a single ventricle and especially the valve regurgitation and the pulmonary arterial group, we are trying to do our best, but still, for surgical technique nowadays, I'm doing the sutureless technique, but still we have many mountains to overcome.
Thank you for your presentation. I'm so impressed of the stent insertion, the Ductus venosus for obstructive PVR. I have one question about the timing of the pulmonary bending because this kind of patient is very susceptible for volume overload, and these patients easily go to the AVBL aggravation in this patient. So after the relief of the pulmonary venous obstruction, the patient's saturation think a little bit high. So how could you decide the timing of the pulmonary bending?
Well, as you know, right after the birth, we cannot measure the exact the pulmonary stenosis severity, and right after birth, we predict the pulmonary stenosis will getting a little worse, but after the 10 days after the birth, the pulmonary stenosis was still mild, and we decided to surgery. Honestly, there was the Shinhyeung's patient, and there was no my opinion. But at that time, the tachypnea and the pulmonary congestion is getting progressed very rapidly. So I think we decided to surgery.
Yeah, so
Soon.
Dr. Kwak, it's not your fault. Actually, I remember that Dr. Robert Freedom, he wrote a review article in ATS in 1998, maybe. What was I was so impressed was the great doctor, Dr. Robert Freedom, mentioned that the obstructive TAPVL in single ventricle right isomerism, maybe the transplantation may be the only answer. I was so impressed. Even in the Toronto Children's Hospital, one of the top institutions at the moment at the time, and so actually now we have very improved result, but still in this kind of patient we have very the challenging the cases. Yeah, Dr. Warakan, please.
Congratulations. I think this is very fascinating case. Unfortunately, I cannot, I did not start from the beginning till now, but just to share with you that the obstructed TAPVR, especially like infracardiac type like this, in my country nowadays, the surgeon are more happy for us to do stenting because it's buying the time. In the textbook, they will say obstructed TAPVR is emergency surgical case, but now it's urgency or emergency catheter intervention case. So, that relieve a lot of the obstruction, and that helps a lot after few weeks or months that the surgeon can go to the theater with less, worry on the pulmonary hypertensive crisis post-procedure. So that's the thing. And just this morning, I listened to the PCSI meeting in India. So the surgeon in India, he mentioned that for the babies less than 2 kilos, the mortality rate there is very high in obstructed TAPVR. So again, I think it's around the world. If we could somehow stenting it and buy the time and allows the baby to heal or recovering from, very congested lung, that may help. Thank you.
In addition, this patient, they had right isomerism and single ventricle, functional single ventricle patient. Yeah, okay.
Thank you.
Now we finished. Thank you, Dr. Kwak.